So what happens when a mother's immune system, the exact biological shield that's designed to keep her baby safe, just turns into a Trojan horse?
It's a terrifying thought, honestly.
Right, because we usually think of a medical diagnosis as this incredibly precise thing, like you break your arm, the x-ray shows a jagged white line, the doctor points to it, and, well, that's that.
Yeah, it's a very comforting binary way of looking at the body. I mean, broken or not broken, you can see it, so you can fix it.
Exactly. But then you step into the world of systemic autoimmune diseases, and suddenly that x-ray machine is just completely useless.
Oh, totally useless.
We're looking at a diagnostic landscape that is murky, it's unpredictable, and it's frankly full of hidden traps. So, welcome to the deep dive.
Happy to be here.
Our mission today is to unpack a massive stack of medical guidelines, clinical reviews, and laboratory explainers to understand how two very specific microscopic flags serve as absolutely critical biomarkers in modern medicine. And those are anti-ssa and anti-ssb antibodies.
And we are pulling from some incredibly robust sources to really piece this together. We're analyzing the UK's Right Decisions clinical guidelines, highly specific maternal medicine pathways from Southwest London and Surrey heartlands.
Which are intense, by the way.
Very, along with deep dives on laboratory assay results from Health Matters and extensive clinical research on autoimmune management from journals like Frontiers.
Yeah, so whether you are a medical professional looking for a refresher, or maybe someone actively navigating an autoimmune diagnosis, or just, an insanely curious learner, this deep dive is for you.
It really is.
Because we're going to reveal how finding these specific antibodies in a blood test can fundamentally alter a patient's life. And crucially, how they dictate the survival of their unborn child.
The clinical journey we see in these documents, it really highlights the profound power and honestly the frustrating limits of modern diagnostics.
Absolutely. But before we dive into the life-altering stakes, we really have to understand what these biomarkers actually are.
Right. Let's set the baseline.
Because in the past, people have compared autoantibodies to a confused check engine light. But based on the clinical literature we read, that feels, way too passive.
Yeah, it doesn't really capture the aggression of it.
Exactly. Reading through this, it feels much more like a corrupted targeting system and a guided missile. Your immune system is this massive defense network, and it's built to lock on to foreign invaders like viruses or bacteria. But here, the targeting software is glitching. It's locking on to the body's own healthy proteins and calling down friendly fire.
That's a great way to put it.
So when a patient looks at their lab report and sees anti-ssa or anti-ssb flagged, what exactly has the missile locked onto?
Well, the immune system has chosen some very specific cellular machinery to attack. So these antibodies are directed against proteins located deep inside our cells, specifically known as the Rho and La antigens.
Okay, Rho and La.
Right. And you will usually see them written on a chart as SSRO or SSB-La. To clarify the terminology for a moment, the antigen is the target. It's the biological protein the body made.
And the antibody is the missile.
Exactly. The antibody is the missile the immune system built to attack it. When we detect these specific missiles in the blood, they act as the hallmark biomarkers for two major autoimmune conditions.
Which are Sjögren's syndrome and lupus, right?
Spot on. Primary Sjögren's syndrome and systemic lupus erythematosus, which, most people just call lupus.
So how common are we talking? Like if my blood test shows this friendly fire happening, is my diagnosis just locked in?
Well, anti-ssa is found in roughly 60 to 90% of patients with primary Sjögren's syndrome.
Wow, that's a huge percentage.
It is, and that is a condition that primarily attacks the moisture-producing glands, so it causes severe dry eyes and dry mouth, though it can go much deeper into the organs.
And what about lupus?
In lupus, which is a broader systemic disease affecting the skin, joints, kidneys, the brain, you see these same antibodies in about 30 to 40% of cases.
Okay, so the sources spent a lot of time breaking down how to actually read the laboratory assay results, which is where I imagine patients often find themselves staring at a patient portal screen in an absolute panic.
Oh, all the time. The numbers can be very intimidating without context.
Right, so they explain the antibody index, or the AI scale. The example given contrasts the result showing a 0.2 versus an 8.0, Break down the mechanics of that scale for us.
Sure. So on most of these laboratory assays, a result like zero point 0.2 represents the lower limit of detection. It's effectively just the background noise of the chemical test.
So it's not truly zero.
No biological sample is perfectly silent, right?
Right.
But a zero point 0.2 means no statistically significant antibodies were detected. It is a clean negative result.
But the 8.0?
A result of 8.0 is a screaming siren. The typical cutoff for a positive result is 1.0. So an 8.0 means the blood is absolutely saturated with these autoantibodies.
Oh, wow.
Yeah, the immune system is actively manufacturing millions of these misguided missiles.
Okay, but I have to push back on the inevitability of this, though. Like, if I get my blood drawing and I score an 8.0, does that automatically mean I have Sjogren's or Lucas? Because the presence of the missile means the war has started, right?
You would assume so, but the human body refuses to be that simple.
Naturally.
A positive result is a critical piece of the puzzle, but it is never the whole picture. Some perfectly healthy individuals carry these highly elevated antibodies without ever developing a single symptom of disease.
Wait, really? None at all?
None. Their immune system is producing the missiles, but for reasons we don't fully understand yet, the missiles aren't causing structural damage to the tissue.
They just have the antibodies floating around on standby.
Exactly. And the reverse scenario also haunts rheumatologists.
How so?
Between 10 and 30% of patients with full-blown Sjogren's syndrome are what we call seronegative.
Seronegative,
Meaning they have the disease, they have the severe symptoms, they might even have the characteristic destruction of their salivary glands visible on a tissue biopsy, but they do not have a single anti-ssa or anti-ssb antibody in their blood.
That is wild. The X-ray is truly broken in those cases.
It is. You can have the disease without the marker and the marker without the disease. It forces doctors to be detectives rather than just reading a spreadsheet.
And the detective work gets even more granular, doesn't it?
Yeah.
Because the sources point out that the most common clinical pattern in Sjogren's is actually testing positive for the SSA antibody, but negative for SSB.
Yes. About 40 to 50% of cases present exactly like that. Furthermore, the SSA, the Rho antigen, it actually has two distinct biological components, Rho 52 and Rho 60.
Yeah, I noticed that in the Health Matters explainer. Why does the body care if it's 52 or 60? Like, what is the actual mechanism making them different?
Well, they serve completely different functions inside the cell, so attacking them causes totally different fallout. Rho 60 is a ring-shaped protein that acts a bit like a cellular garbage disposal. It binds to misfolded RNA to clean up the cell. Antibodies attacking Rho 60 are the classic hallmark of Sjogren's and lupus.
And what about Rho 52?
Rho 52, on the other hand, is a protein involved in regulating the immune response itself. It helps put the brakes on inflammation.
So if the autoantibody attacks Rho 52, it's essentially destroying the body's own immune brakes.
Exactly, which leads to rampant, unchecked inflammation. Clinically, Rho 52 autoantibodies are frequently linked to interstitial lung disease, inflammatory muscle issues, and systemic sclerosis.
I see.
So by diving into the specific molecular weight of the antigen under attack, the 52 versus the 60, the physician gets a preview of which specific organs might be in the crosshairs.
That makes a lot of sense. So we have these biomarkers indicating severe autoimmune activity, or at least the potential for it, in an adult. But looking at the maternal medicine pathways from Southwest London, this is where the story shifts drastically.
It really does.
We have to look at what happens when this adult patient becomes pregnant. Because at that exact moment, anti-SSA and anti-SSB transform. They aren't just diagnostic markers for the mother anymore. They become critical, predictive biomarkers for a second life.
Yes. We call it the two-patient dilemma.
Yeah.
And the core mechanical issue causing this dilemma comes down to the structural classification of the antibody. Anti-SSA and anti-SSB are what we call IgG antibodies.
Right. And from reading the pathways, the IgG part is the linchpin because of how the human placenta operates. The placenta isn't just a passive physical wall. It has active transport mechanisms.
Correct.
Specifically, these receptors called FcRn that are designed to grab IgG antibodies from the mother's blood and shuttle them right across to the baby.
The biological intent is beautiful, honestly. In a healthy pregnancy, a mother's immune system pumps her own protective IgG antibodies across the placenta to give the baby passive immunity against infections like measles or the flu before the baby's own immune system comes online.
It's basically a care package of immune defenses.
That's a perfect way to describe it.
But the placental receptors aren't a smart filter, are they? They just see the shape of an IgG molecule and transport it. They have absolutely no way of knowing that these specific IgG antibodies are a corrupted targeting system.
They don't. So starting around the 16th week of pregnancy and peaking up to week 30, the mother's body actively pumps these harmful anti-ssa and anti-ssb antibodies directly into the developing fetus's bloodstream.
The Trojan horse.
Exactly.
The mother's immune defenses unknowingly sending a destructive package right into the baby's circulatory system. So, when those antibodies arrive in the fetus, what is the biological fallout?
It induces a condition called neonatal lupus syndrome, or NLS, and NLS presents in two main ways, driven by where those antibodies decide to bind.
Okay, what's the first way?
The first presentation is transient, meaning it's temporary. The baby might be born with a skin rash, maybe some liver abnormalities, or low blood counts.
That sounds terrifying for a parent.
It is, but because these are the mother's antibodies, not the baby's, once the baby is born and the umbilical cord is cut, the supply stops.
Oh.
The existing antibodies eventually degrade and clear out of the baby's system over a few months, and those symptoms fade away completely.
Well, that's a relief. It sounds incredibly stressful, but manageable since it resolves.
Yeah.
But the second presentation outlined in the maternal guidelines is much darker.
Yes. The second presentation is permanent. It is called congenital heart block, or CHB.
Heart block.
Right. The autoantibodies cross the placenta, and they specifically bind to the cells in the electrical conduction system of the developing baby's heart, specifically the AV node, which acts as the heart's electrical relay station.
And once they bind, they trigger that friendly fire we talked about.
Exactly. The antibodies act as a beacon. The baby's developing macrophages, which are immune cleanup cells. They see those antibodies, assume the heart tissue is an invader, and rush in.
Oh, no.
They cause massive inflammation, which eventually leads to calcification and scarring of the delicate electrical nodes. And electricity cannot travel through scar tissue.
So the signal just stops.
Once that AV node is scarred, the electrical signal from the top of the heart can't reach the bottom of the heart to tell it to pump. The heart block is completely irreversible.
Man. What are the actual clinical stakes here? Because we know the mechanism is terrifying, but how likely is this to actually happen to an anti-SSA positive mother?
Well, for a mother who is navigating her first pregnancy with a positive anti-SSA biomarker, the risk of her baby developing congenital heart block is roughly 2%.
Just 2%. I mean, from a sheer numbers perspective, that is relatively low. But obviously, when it's your child, a 1 in 50 shot of permanent heart damage is just... it's terrifying.
Of course, but the medical calculus shifts violently depending on the mother's history.
How so?
If she has had a previous pregnancy affected by heart block, the risk for the current pregnancy skyrockets to 15 to 20%. The immune system has essentially learned the pathway and strikes with far greater efficiency the second time around.
Wow. Okay, so if we know this Trojan horse is coming, and we know exactly when the placental gates open, between weeks 16 and 30, how do maternal medicine networks use these biomarkers to protect the baby? Because the guidelines make it very clear they don't just sit and wait.
No, they don't. Because the biomarkers give us the exact timeline of the threat, doctors can launch a highly structured surveillance mission. Looking at the protocols from the Southwest London and Surrey Heartland's maternal medicine network, the monitoring is rigorous.
I can imagine.
Women carrying these biomarkers require specialized fetal echocardiograms, which are incredibly detailed ultrasounds focusing solely on the architecture and electrical rhythm of the baby's heart. And those happen specifically at 16 and 24 weeks.
So they're looking for the earliest signs of inflammation before the scar tissue sets in. But the surveillance goes beyond just 2 ultrasounds, right?
Much beyond. The guidelines mandate weekly monitoring of the fetal heart rate using a Doptone monitor starting at 18 weeks.
And a Doptone is essentially a handheld ultrasound.
Right.
It relies on the Doppler effect,
Right.
bouncing high-frequency sound waves off the moving red blood cells inside the tiny fetal heart. The machine translates the shift in those sound waves into an audible heartbeat.
Exactly. And every single week, the clinical team is listening for very specific mathematical thresholds. A normal fetal heart rate is incredibly fast, usually between 120 and 160 beats per minute.
That fast.
Yeah, fetal hearts are so small, they can't pump a large volume of blood with each squeeze, so they have to pump very fast to maintain enough blood pressure to survive.
Right, so if the heart rate drops, the baby's entire circulatory system is in jeopardy.
If the doptone registers a heart rate dropping below 100 beats per minute, it triggers an urgent referral to fetal cardiology.
Okay.
If the electrical scarring has progressed to the point where the heart rate drops below 55 beats per minute, it is considered a severe risk factor for fetal and neonatal death. The baby simply cannot maintain blood flow.
God, that's heavy.
In those cases, the neonatal cardiology team often has to prepare to surgically implant a pacemaker in the baby's chest immediately after birth.
I just can't imagine going in every week, holding your breath while the cold gel is on your stomach, just waiting to hear how fast that little heart is beating. The psychological toll must be immense.
It really is.
But wait, if they catch the heart rate dropping at week 20, if they hear it dip to 90 beats per minute, what is the medical intervention? Like, how do they stop the macrophages from scarring the heart block before baby is born?
This is perhaps the most sobering reality detailed in the source material. Currently, there is no proven preventative treatment for fetal heart block prior to birth.
There has to be something. What about IV, intravenous immunoglobulin?
Right.
Based on the literature, that involves giving the mother a massive infusion of pooled antibodies from thousands of healthy donors.
Right.
The theory is that it floods the mother's system, overwhelming her placental receptors, so they grab the harmless donor antibodies instead of her destructive autoantibodies.
It is a brilliant biological theory, but the clinical data shows it fails in practice. The sheer volume and binding affinity of the mother's autoantibodies outcompete the donor antibodies. So IVIGs has not been established as effective prevention for heart block.
What about steroids then? Like dexamethasone is a heavy-hitting fluorinated steroid specifically designed to cross the placenta. It shuts down inflammation.
It does. Dexamethasone does cross the placenta beautifully, and it does suppress inflammation. But by the time a doptone monitor detects a dropped heart rate, the microscopic damage has often already begun.
And you can't reverse it.
Exactly. Steroids cannot dissolve existing scar tissue. The guidelines explicitly state that maternal steroid therapy is not recommended as a prophylactic to prevent the block.
So the power of the biomarker here isn't about prevention at all. It is entirely about preparation. It's an early warning system.
That's exactly it. It's about knowing the precise risk, monitoring the threat in real time, and having the pediatric cardiothoracic surgical team scrubbed in and standing by in the delivery room the exact moment that baby takes his first breath. The biomarker gives you the gift of time to prepare a life-saving response, even if it can't give you a pharmaceutical cure.
That makes total sense.
Yeah.
But the sheer medical intervention required just to get this baby safely delivered is staggering. We're talking weekly monitoring, surgical teams on standby. So the moment that baby is out and breathing, you'd assume the threat of these biomarkers is neutralized. The placenta is gone. The transport mechanism is gone. The mother can finally take a breath.
You would think so, but no.
No.
The mechanism transferring the risk to the baby is gone, but the biological upheaval for the mother has just reached its absolute peak.
Wait, why?
If we examine the broader research in the Frontiers Journal, the period immediately following birth, the postpartum period, is a highly vulnerable, yet massively underexplored danger zone.
But if a mother's lupus or Sjogren's was totally stable during the entire pregnancy, why would it suddenly flare up after the baby is born?
You have to look at the massive hormonal crash that occurs. During pregnancy, the mother's body produces sky-high levels of estrogen and progesterone, and these hormones are naturally immunosuppressive.
Okay, because they have to be.
Exactly. They have to be. Otherwise, the mother's immune system would recognize the fetus as a foreign parasite and reject it.
Wow, so the pregnancy itself is acting like a systemic off switch for her autoimmune disease.
The moment the placenta is delivered, those hormone levels plummet. That natural immune suppression disappears in a matter of hours. The immune system rebounds like a stretched rubber band snapping back.
That sounds intense.
Add in the immense physical trauma and tissue damage of childbirth, which triggers a massive inflammatory cascade as the body tries to heal, and you have an absolute perfect storm for autoimmune disease to reactivate.
I see.
The sources show that in real-world cohorts, 20% to 40% of women with SLE experience mild to moderate disease flares during their first year postpartum.
So you're trying to care for a newborn, you aren't sleeping, your hormones are crashing, and suddenly your own immune system decides to launch an aggressive attack on your joints or your kidneys. That is brutal.
And the danger extends beyond inflammatory flares. There is a severely heightened risk of systemic infections and, crucially, venous thromboembolism, blood clots.
Which, I mean, the postpartum period is already naturally a prothrombotic state. The The body increases blood clotting factors to stop the mother from hemorrhaging after birth.
Exactly. You take that natural hyperclotting state and you dump systemic autoimmune inflammation and roaming autoantibodies into the circulatory system. The risk of dangerous, potentially fatal blood clots multiplies exponentially.
So we have a mother dealing with massive immunological shifts, the threat of organ flares, and a high risk of blood clots. The obvious medical answer is medication, right? Immunosuppressants, blood thinners.
Yes, clinically speaking.
But introducing medication during the postpartum period introduces a completely different, almost psychological barrier.
This brings us to a massive gap between clinical guidelines and real-life patient education. It represents a true tragic irony in the source material.
How so?
Many women with these conditions absolutely require immunosuppressive medications to stay healthy and keep their disease from destroying their organs. And an increasing number of these standard medications are actually perfectly safe to take while breastfeeding. They do not cross into the breast milk in any clinically significant amount.
But the mother doesn't always know that. Or, she doesn't trust it.
Out of an unfounded, deep-seated fear that the medication will pass through the milk and harm their fragile newborn, many women unilaterally stop taking their essential medications.
Oh, man. They sacrifice their own health, medically unnecessarily, because their protective instinct just overrides their doctor's advice.
Exactly. This medically unnecessary discontinuation directly causes dangerous disease flares. The mother gets incredibly sick, she becomes physically unable to care for her child, and she often has to stop breastfeeding anyway because she requires hospitalization or massive doses of rescue medications that actually are unsafe for the baby.
It's a vicious cycle.
The sources highlight that concerns about medication safety are a leading cause of delayed or abandoned breastfeeding in these populations. It underscores a desperate need for better, more empathetic counseling in the postpartum period, really explaining the mechanics of these drugs to terrified new parents.
Right, because knowing the biology is only half the battle. Communicating it effectively to someone operating on 2 hours of sleep and pure adrenaline is just as important. Well, let's bring this all together. We've gone on quite the journey with these anti-ssa and anti-ssb antibodies. We started by looking at them as a corrupted targeting system for diseases like Sjogren's and lupus. We saw how the simple numbers on a lab report, like a 0.2 versus an 8.0, carry immense weight, dictating which specific proteins and organs are under attack, yet still require a doctor's context to solve the seronegative paradox.
We followed those antibodies across the placental barrier, witnessing how a mechanism designed to protect a baby can accidentally deliver a permanent, life-altering heart condition. The biomarkers transformed into a critical radar system that dictates intense weekly medical surveillance using Doppler mechanics, buying surgeons the time they need to prepare.
And finally, we saw how the biological shadow of those antibodies lingers long into the postpartum period. The hormonal crash of estrogen and progesterone triggers massive disease flares, forcing mothers into heartbreaking dilemmas about their medication and their ability to safely breastfeed. It is an incredibly complex web spun by a single drop of blood.
I'd like to leave you with one final thought to mull over, something that rheumatology researchers are actively struggling with right now. We discussed earlier that these exact autoantibodies can be present in perfectly healthy people.
Right, people who never show a single symptom.
People who never show a single symptom of Sjogren's or lupus their entire lives. They have the 8.0 on the lab test, the missiles are in the air, but they never strike a target.
The silent biomarker.
Exactly. So what is the invisible tipping point? What is the exact biological trigger? Is it an unknown viral infection, a massive environmental stressor, maybe a specific genetic mutation coming online? What takes these silent, benign biomarkers and suddenly flips a switch, turning them into the active, destructive drivers of chronic autoimmune disease?
That's a great question.
The antibodies are identical under a microscope, but the clinical outcome is vastly different. Finding that switch is the holy grail of autoimmune research.
It makes you wonder how much is happening inside of us right now, just waiting for the right or, wrong push.
He really does.
Well, thank you for joining us on this deep dive. Keep questioning the things you think you know. Keep digging into the hidden mechanics of the world around you, and take a moment to appreciate the profound stories swimming in every single drop of your blood. Until next time.